We're going to give folks a moment to join. In the meantime, you should be able to see our screen, which has a topic we'll be focusing on today. We are super excited to have Miss Marisa Renee Lee with us, along with Dr. Swiderski. Unfortunately, Dr. El-Hakim wasn't able to join us today. And we're going to be talking about grief in medicine. And so please get settled, make yourself comfortable. We will get started in a moment. And I want to kind of remind us of our format for today, which is really great because it's more of a conversation than I think some of our other rounds. We'll be talking first to Marisa, and then we'll be talking with Debbie. And this is a real community conversation. And so my hope is that folks will put questions in the chat, will pipe up and ask questions. I think that having the intimacy in this setting that we have with Marisa will really lend itself to some wonderful conversation. And so come in, tell your buddies to come on in. If you're coming in as Monty resident, please go ahead and change your name to your name so we know who's in the space. We love when folks are on camera, just so we can see you and feel like we're all in the same room. If you're able to, if you're not, we totally understand. And so come on in and get settled, and we'll get started in a minute. Okay, so we're going to go ahead and get started. Hello, everyone. Thank you for being in this space. I know folks will continue to come in as they finish clinic and as they get off the floors. I am Stella Sappho, and I'm going to be moderating our discussion for today. As a reminder of the space that we're in, social medicine rounds were really created as an opportunity for us to connect with staff, faculty, trainees, and community members around the medical, economic, and psychosocial issues that impact Bronx residents and impact us as healthcare workers and healthcare providers. And one of the reasons why we've kept ourselves in this virtual space is because social medicine rounds really felt like it was important to be a space that we can invite community members into. And so these are the rounds where we're having real talk. We're talking to folks with lived experience. We are allowing ourselves to really be in conversation and in community with individuals who are, folks that we may not necessarily be able to have some of these conversations with in the clinical space or in the hospital setting. And so with that in mind, it is very, very exciting today to be able to have this conversation about grief and its place in healthcare with, I would call, someone who's a grief expert. And one of the kind of third people in this room, if you don't have it, I would say is Marisa Renee Lee's book. So Marisa and I, just for full disclosure, went to college together, and I had the pleasure of seeing her, go on her book tour and speak about this book. And it really changed my experience to grief at the time that I read it, and I've reread it for these rounds, and I highly encourage everyone to please pick it up. I'm going to turn it over to Dr. Iyer to please introduce our speakers, and we'll go ahead and get started.
All right. Good afternoon, everybody. I'm excited to be here with our wonderful speakers. I just gonna pull up the bios here. So I'm going to introduce Miss Marisa Renee Lee. Let me know if I pronounce that wrong. Who is an award-winning advocate, writer, and speaker on coping with grief and loss of all forms. The past 2 decades of her life have been marked by loss, first of her mother, then of a much-wanted pregnancy and her fertility, and finally of the early and tragic deaths of her cousin, Ebony, to COVID, and more recently, Imani, to domestic violence. These losses transformed her life and led her to question what grief really is and what healing truly requires. She's the author of Grief is Love, and we're very excited to hear from her today. Our second speaker is Dr. Swiderski, who received her BA from Barnard College and her medical degree from Columbia University College of Physicians and Surgeons. She completed her residency in internal medicine here at Montefiore Medical Center. She's a professor of medicine with a joint appointment in family and social medicine at the Albert Einstein College of Medicine. She has served as a clinician educator for her entire career and the director of the psychosocial curriculum in the residency program in social medicine at Montefiore Medical Center from 1988 to 2021. She's a primary care internist whose practice is located in the South Bronx. Her areas of scholarly focus include the psychosocial aspects of adult primary care, the influence of the physician-patient relationship on medical care, end of life, and bioethics. She's been the clinical lead on the Serious Illness Conversation Project at Montefiore Health System since its inception in 2018. So I'm excited to have Dr. Swiderski here in conversation with us as well. And I'm going to hand it over to Miss Marisa. Does that sound okay?
Yes.
Great.
So thank you so much, Dr. Iyer. So I am very excited. I get to be in conversation with Marisa to start. And I feel like we're in our house just talking. And so I will have to remind us to come back into this space. There is so much that I want to ask you about the book. And I really want to say that in addition to being a professional, the badass that she is, an author, Marisa is also coming to us as a patient, as someone who's experienced the healthcare system, both as a caretaker and as someone who has been a patient. And I want to really draw that into this space because I think, especially when we speak with Dr. Swiderski, the kind of lived experience as a caretaker, as a patient, really informs a lot of what you talk about with grief. And so just to kind of get us started, why did you write this book? Why did you feel compelled to write this book as a Black woman who had lost her mom in her 20s and had kind of gone through it, and some would say gone through it successfully? I mean, you are thriving, worked in the Obama White House, have your own business, just fabulous in so many ways, and yet you took the time and space to write this book on grief. And I'm just curious as to what the why is, and as you're thinking through that, what we as clinicians can pick up from this kind of a framing of grief.
So I will give you my why, but before I do that, I feel like I have to flag something for everyone. I am a work from home mom, and my son is almost 3, and he is accustomed to me being done at 5 o'clock if I'm still in this house. And so apologies in advance if you end up meeting Bennett this evening. Now that meeting him or hearing him, I should say, because he is incredibly loud, like shockingly loud sometimes. So in terms of my why, it's a great question. I'll tell you, my mom passed away, for folks who are not personal friends who I went to college with or people who've read my book. She passed away in 2008, in February of that year. And I really believed in the lead up to her death. I worked hard, I was organized, I was honest and realistic about the fact that she was dying. I wasn't my dad who was praying for a miracle until the end. I was like, she's had MS since I was a teenager, and she also has stage 4 breast cancer. Like, this is only going in one direction. And I thought that because I was honest about it, because I did a bunch of research on grief and loss and death and dying, I had the hard conversations with mom, and I did all of the things. And so I was like, when she dies, it's going to be sad, but it's going to be fine. Like, I'm going to be okay. I've got a plan. And then she died. And my plan went to shit. And I was destroyed. I was a mess. And I didn't know what to do without my mom. And I really, really struggled. Like, those first 6 months or so were some of the worst times of my life. And something shifted for me that summer. And I basically went from feeling like there was something wrong with me to recognizing that I wasn't the problem. The problem is in how we treat grief and loss in this country, in our culture, how we treat grieving people, how we treat death and dying, and all of it. And so I decided in August of 2008 that I was going to write a book about grief and loss, and it would not be sad and depressing, and it would be a bestseller. And then I didn't do that right away. I moved out of the city, worked on my own grief, started working for former President Obama. I did all of these other things. And as I worked through the pain of infertility and a really difficult pregnancy loss at the end of 2019, right before we all lived through the grief of the pandemic, I was forced to reckon with how much I was struggling in that moment. And my husband and I at the time, we didn't have a backup plan. Like we'd spent all the money and tried all the things, and we were lost. And there was no longer an option of going and grabbing drinks with friends as a distraction, or even attending in-person therapy or church services. And one of the only things that had always been a part of my coping toolkit that I could still do in the way that I wanted to was write. And so I started writing like crazy in early 2020. And that led to an article that went somewhat viral that then led to the book Grief is Love. And at that time, I hadn't fully delved into all of the research around grief and loss and healing, but I just felt like we weren't doing it right. I felt like these concepts around moving on and getting over it, they just didn't make sense to me. They'd never made sense to me. And they super did not make sense to me in 2020 as we were all witnessing like just mass death and loss and grief. And so I needed to do something. I needed to like do something about it. I needed to put something out there. And that's where it started. And once I committed, I mean, I was all in, and here we are.
And here we are. And when we were thinking and we were prepping for this conversation, we talked so much about the role of grief in healthcare, and definitely want to hear from Dr. Swiderski and others who are clinicians and providers in this space. But I'm curious for you, you wrote this book for a lay audience. I would say you wrote this book in some ways for Black women who struggle with how to deal with grief, because you tell us to give ourselves permission and care and reflection. And but I'm curious about your kind of reflections on how this relates to us as healthcare workers, and what we should be thinking about and taking, as someone who's experienced the healthcare, I would
Yeah.
say, delivery system, knowing what you know from your perspective, how you see your book in conversation with those who are healers and clinicians and people who provide care.
Yeah, so I think about this in a couple of different ways. First of all, I, and I'll get into this a little bit, but as you know, I'm currently a very active patient, unfortunately, right now. I have been dealing with some post-COVID complications the last couple of months, and that has meant lots of doctor's appointments, lots of follow-up, fighting with insurance companies, tests, just all of it. And it is hard and stressful and full of grief, and also a little bit of trauma, just as someone who was with their mom who, was diagnosed with some unknown thing when she was 13. It's really hard. And it is absolutely full of grief. And so I think of healthcare workers as being on the front lines of grief in multiple forms. There is both just, I think, the grief that comes from constantly having to encounter and deal with the pain of others. Like, I think that is very real grief that healthcare workers have to carry. And I also saw this personally as someone who's married to a person who was a frontline healthcare worker during the pandemic. Like, I think there is grief in what I have seen post pandemic as like a lack of recognition for all of the work and care that you all provided on behalf of the rest of us. So there is also that grief that I think is really real for healthcare workers. And then I think there's a lot of grief that many people, particularly when I think about the communities that you serve, have when it comes to the healthcare system. There are a lot of people that you're trying to take care of and trying to help who haven't been listened to, who have felt ignored and left behind, who have not received not only the compassion and empathy that they deserve from the healthcare system, but in a lot of cases, they haven't even received like the basic care that they deserve from the healthcare system. They don't feel safe in hospitals or in doctor's offices. And so I think having an awareness for that grief that many of your patients carry is another really important piece of this. And, doing all that you can, knowing that you all face a lot of challenges too, to hold space for that grief and really listen to people and care for them with the compassion and empathy that they deserve is so important. And that is a big part of why, even not feeling my best, I was really happy to be here today.
And I so appreciate that. I want to just kind of highlight some of your words and words of some of the researchers that you spoke about in the book. And one thing that you talk about, I think really relates to how you just answered the question about, so why healthcare is that in healthcare, there's so many emotions, there's fear, there's sadness, there's worry. And we don't often, I think, get to name grief as it relates to some of the intensity of experiences that we see. And you talk about researcher Dr. Hollinger saying to name feelings, to give words, either spoken or unspoken, to emotions that are overwhelming, controls the power of those emotions, harnessing them and lessening their intensity. And so one of our goals just with this session is to give us space as healthcare workers and some of us as patients as well, to be able to say, the reason why this experience is particularly hard is that it's grief. It's grief that I'm feeling and experiencing.
Absolutely.
I want to talk about one thing that I love about the way that you kind of give us these lessons. If you talk about how sometimes you just didn't do it the best way and you were struggling through it. And so there's one point where you talk about striving has always been my answer to trauma. I took care of myself by literally taking care of myself and ensuring that all the bad things that happened to me didn't get in the way of my success. And I just, and then at some point you say I couldn't do it anymore. It makes me think a little bit, and I definitely want to get Dr. Swiderski's opinions on this when we bring her into the conversation about like, what is a grief practice? You really name some of the elements you can bring in, which is care, patience, permissioning, vulnerability. You name them so beautifully and simply and give examples. But I'm curious, having done this work, having been to so many spaces where you've had these conversations, how do you think about a grief practice, if that even like holds, resonance with you? And how do you think folks should think about it or approach it?
Yeah, it's an interesting question because, particularly in this space and time that we're living in, where people are very quick to package things into practices for social media or for the purposes of commodifying them, frankly, to think about a grief practice. And for me, and not just based on my personal experiences, but also based on the research, like grief is very unique. If you lose a parent, the way that you respond to that grief, to that loss, it's going to be different from the parent's partner or another child or their sibling, etc., because all of us had a different relationship with the deceased. And so I think starting from a place of understanding that your grief practice and even what I describe may not be the thing that works for somebody else. And that is okay. That's not just okay, that is normal. Like, let me say that is normal. And so when I think about a grief practice, it is very much about finding the individual things that we know based on research and science contribute to healing and physical and mental health that work for you. And so for me, writing has always been a big part of my grief practice. Exercise has always been a big part of my grief practice. Meditation and, sort of trying out different mindfulness techniques have also been a part of my grief practice. Travel has generally been a part of my grief practice too. Like, frankly, even when I couldn't afford it, like I've always found that really healing, especially when it comes to being close to the water, because that's just something I identify with my mom.
I
All
love
of
that.
these
And you
things.
mentioned going to Miami and meeting Seal on the anniversary of your mom's death. Yeah.
Oh my God, it was hilarious. For context for everyone, it was my mom. There's 10 days between my mom's birthday and the anniversary of her death. And I knew that that was going to be a hard period. I didn't realize how hard it was going to be, but I also, there was something about it. I was 25 years old and I just knew that I didn't want to be around other people. Like, I just knew I wanted to be alone and I wanted to go to the beach. And it was February. So like, I definitely didn't want to be in New York City in February. Like, it's cold and dark and, it's not Christmas time. What are you going to do? And so I got on a plane and I went to Miami by myself. for my first ever in my life solo trip. And as I was heading to the airport, back then you actually had to like physically check out of the hotel. So I'm like finishing up checkout and getting my bags. And I look up and I'm like, wow, that is just like fundamentally, inarguably, like just like a beautiful man. Like I was just like, wow, cool. Like nice to like see somebody like just so attractive as you're leaving Miami. And then I heard him speak and like he had to walk by me and like, said, excuse me or whatever. And I was like, oh my God, that's Seal. Like this, like I did exactly the right thing. I came to exactly where I was meant to be. And my mom is so proud of me. Like this is
Yes,
her way of
sending you
being there.
signs.
So yeah, so back to just circle back to grief practice. Um, it's identifying your toolkit. Just like right now, as I navigate these health challenges as, a mom, a business owner, and a writer, I have a toolkit of things that have helped me with these like really aggressive, horrible headaches. And, just like you might advise a patient to turn to the things that help them, relieve their pain, it's about thinking through, what are the 3 to 5 things that I know help me when I'm dealing with a difficult emotional situation.
Mhm.
So yeah, I don't want to be too prescriptive because it is different for everyone.
It makes so much sense. And I think it's a really great point to bring in Dr. Swiderski. And so let me just highlight her as well. And so Dr. Swiderski, one of the reasons why I wanted Debbie to join us in this conversation is, and I want to again name that Dr. El Hakim couldn't be with us because I think he's doing a really good job of preventing kind of the burnout and the challenges that happen when you work as hard as he has. But I just want to name that he has been so helpful in framing some of these questions and combos this combo that we're having. But our hope when we kind of pull this together was to say, what's it like when you talk to a seasoned clinician, someone who's had the years and the seasoning that comes with that and has seen some stuff, right? In the healthcare journey, in the healthcare setting rather, and also, Debbie, I think you've spoken to it so beautifully, have experienced personal grief and challenges in your own way while showing up as a caretaker and a loved one for people. And so we really wanted to get your perspectives. And what I particularly wanted to highlight for our trainees listening is how to the question that I just asked Marisa, how you've kind of thought through a grief practice, grief in the clinical space, et cetera. Before we get to that though, I just want to get your kind of high level reactions to Grief is Love. I know one of the first things Debbie said to me when I reached out to her to do this, she was like, I need the book immediately. I need to read it. I need time to really, let it sink into my spirit. And so we'd just love to hear your reflections as someone who is a healthcare provider and a person in this world taking this in.
Uh-oh, I'm like, I hope you
No,
like it.
I want to say a deep thank you for the title of the book and for the book. Thank you very much. And I want to start by recapitulating. I want to say that it was clear that you were writing this for those who are experiencing grief and specifically for African American women, I think, which is a special challenged group for this. But I am here to say that most of what you said is universal, I think.
Well, thank
And I
you.
say that speaking from my own personal experience and having been, a clinician, a primary care doctor for over 40 years and helping other people go through it and listening to them. And so I can say to you that a lot of what you've written is universal, I think.
So
And for men as well as women. And for men, they have a challenge because they're not supposed to feel anything ever. And so I really thank you for this. And I just wanted to take a minute and go through some of the points which Stella reeled off, but I think for the purpose of this gathering, it's important to name them. I took notes as I read the book. The first is that time stops, or we wish that time would stop when we're hit death, with the loss of someone that we really love. And that is very disorienting. And again, I'm speaking as the person who is grieving, but also as we think about taking care of patients, that they're in a moment of disorientation. It's an existential moment. It's like you're in free fall. How to describe that even? There's no way to describe it. And the wound that is grief is, I'm not using your words, I'm trying to summarize some of the things that you said that were so pertinent and I think universal. There's a wound, it's a wound. It's a terrible wound, particularly in the immediate aftermath of grief. And I think 6 months is one of those time periods, but it could go on longer than that. But the terrible thing is that not only is it a wound that I think often feels physical, and again, I'm speaking to the doctors in the audience, that your patients may come in with chest pain, which I experienced when my sister died. I had pain in my chest. It would not go away. But the terrible thing, and you discussed this, is that it's invisible. No one sees it. And so you're walking around and you look normal, but you're not normal. So not only has time stopped, but you are wounded and it's invisible. And again, I'm speaking, as we think about taking care of patients who are in that moment, that it's terrible to be invisible, to have your suffering be invisible. Another point that you just made is that there's no playbook for this that applies to everyone, for how a person moves through it. And I think that you're right when you said that, well, not just doctors anymore, but yeah, on social media, which I am not on, but, I think it's like, oh, this is the way you do it. It's like, no, there is no way to do it. It's a struggle. It's a big, in fact, what I said after the loss of my husband is, it's a big mess. I'm just in the middle of a big mess here. That's all. And that's the way it is. And you all better accept it because that's how it is. You specifically talked about good and bad feelings. I loved that. And again, I'm just going to repeat this. I'm speaking to those when we experience it ourselves and when we take care of patients. Be ready for folks to have a panoply of emotions that go up and down, in and out. And I was really happy that you made that point, that anger is could be part of it. And you don't want to feel angry at your mom when she's gone and she suffered, but you just might well feel angry and yet to accept that and to work through it. You touched on already, I'm going to repeat things because I think they're so essential and I think they're universal. Our culture does want us to get over it. And Kubler-Ross is one of the big, band leaders for that. But the United States lives in a get over it culture. And in fact, for us doctors, we have the DSM, a Bible of like psychiatric diagnosis. And I meant to consult it before this, but abnormal grief is in there as a diagnosis, and it enrages me. It enrages me. Like I'm sorry to be a little over the top with my adjectives, but it's really not right.
No, it's ridiculous.
It's ridiculous. Yes, it's enraging. Grief and love. And so again, thank you for the title of the book and the framing of this. But I think grief and love are opposite sides of one coin. They go together. And if grief is confronted, then love surfaces. And both of them, you say, they both live on. That's one of the points you made. They continue, which goes back to this notion that you don't get over it. You find a new way to live, but and again, for our patients, the anniversaries, and you don't know when it's going to surface. And it may have physical consequences again for our patients, this resurfacing. And then just that, to allow oneself to feel grief and then to feel the love that comes after that is being vulnerable, and it's a really a whole bunch of work, which you address in your book, and again, I thank you for that. So that's my response to your book, that those are the things that and there are many more, but I think the high points for us to think that are universal as we go through it in our own lives, but also try to take care of our patients.
Do you want to come on book tour with me?
Hmm?
Do you want to come on book tour with me? As promised, Bennett has entered the chat.
Hi,
Her mommy's
Bennett.
talking to you
How are
about
you,
grief, okay?
buddy?
I'll be able to play in a little bit.
He's like, you're on the clock.
Lord, sorry.
Debbie, that was a beautiful summary, and I think one that really kind of highlights the themes again. And I'd be interested in your perspective. It sounds like you also agree there isn't a playbook, there isn't a one size fits all, but for the clinicians, especially the young clinicians that are kind of starting off, what you consider some of the elements, the things that would go into a recipe for a grief practice, that folks can kind of start, hold on to, think through. And I'd like to offer my own after you go, just because I think it's something that you learn through experience and that is, again, very customized and individualized, but you can kind of see how folks are approaching it. And I think that could be helpful. So I'd love to hear your reflections on that.
Right. I want to circle back to something Marisa said about oh, I lost my train of thought. I just want to say that suffering, you mentioned this, grief is, we're talking about death, but so this, you talked about this early on. We practice in the South Bronx, the folks on this call, and we encounter a lot of suffering. And so I think that, it's not just death. Sometimes it's suffering from a life that was not allowed to be, go where it should have gone. It's suffering from terrible illness and not feeling properly taken care of, suffering from trauma. And so I would like to put grief under that umbrella and say that really we're talking about that big umbrella, not just the grief that comes with death. And so it can be, the other thing is, I guess I'd like to talk about, before I get to practice, part of the practice for me has been an undoing. Because we learn that death is the enemy. No one says this, and I'm curious about how the residents on the call feel. But I think that because it's called the hidden curriculum, no one tells us this, but death is the enemy. But of course, death always wins eventually. And then we're not taught with anything about how to deal with that once it happens. And I'm not going to use the word favorite, but the metaphor or the scenario that I talk about is when there's a cardiac arrest and a code is called. It's an incredibly intense experience. And then when the patient doesn't make it, the doctors leave. We're gone. And that's not good for us. And it's not good for the family and the patient, but that's the way it is. The other thing we're taught is that we're supposed to be professional and not project our feelings onto a situation. And I think that it's important to say that there's something to that, because medical care should be about the patient and the family and not about the doctor's feelings, okay, in the moment. And yet, what's in tension with that is that we do have feelings. And to the extent that the system requires us to bury them, does not give us an opportunity to get them out, then it's a disservice to the patients and to us. And so I think, there's some undoing that should go there. What I want to say is that my own learning about this happened from my own loss, which I was a young attending. I was 35 when I lost my sister, my mother, excuse me, and then a series of losses after that. And it allowed me, because I was open in the ways that you talk about in your book, Marissa, but it took a tremendous amount of work on my part, quiet, still work, over since today, on my whole career since then. And because of that, I was able to kind of open myself to my patients to undo some of this undoing that I was talking about, of how I was acculturated to be a doctor. I give myself permission. So I want to just say, in terms of how to care for patients, and then I want to talk a little bit about physician practices around our grief. These things sound very simple, but I think the simplest things are the hardest. So the first is to muster the courage to allow the patient suffering into the room. That sounds so easy. It's very, very hard. And you have to believe as a doctor that, because we're trained to like fix things and do things and get the answers and get the data, and that's not what this is about. And so we have to give ourselves permission and have courage.
And I just want to call out that give ourselves permission is, I think, one of the first things that you actually say, Marissa, is that there is a opening that you have to have. And I noted that line and I said, how do we do that in the clinical space when we have the constraints of time, competencies that we need our residents to get, clinical shifts, et cetera, et cetera. And I just think that
Well,
I want to just hold that up, because I think
take
it's
that
just
time thing
brilliant.
head on and say,
Yeah.
this is, I didn't write this part down, but and there's some more things I want to say about doing it. But I think I have come to understand that when someone comes into me and is grieving, and I now am good enough at this that I can pick up on it, and everything stops, whatever the point of the visit was, is gone. I let the person talk. And the simple things that are hard to do are attentiveness, silence, and, resisting the urge to fix, as I said. But really, when the patient tells the story of whatever the loss is, and they feel my attention and my empathy, I say to them, listen, unless your systolic blood pressure is 200, this visit is not about that, or whatever you can. This visit is about your loss. And 100% of the time, the person says, thank you, doctor. Thank you. So I say, and I have the luxury because I'm a primary care doctor and I'm there every week. I say, if it's the pain in your, I'll see you next week for that. But today we're talking about your loss. And by the way, one time a patient made a same-day appointment to see me because her cat died. It doesn't matter what the loss is. And that's what the visit was about. It was about her cat. And in terms of changing our practice, guys, so yes, the time demon is breathing down our back, and so is I have to take care of the diabetes and the blood pressure, that's breathing down our neck. But, this is hard work to change your practice, to be open. It takes practice. So again, be kind to yourself as a doctor, that just keep trying to do it. Just keep trying to do it. That would be my advice. I just wanted to say just a couple words, if it's okay, if there's time, about physician grief.
Yes, I want to say there is time, and if there are any questions for Marissa, she does have to head a little bit after 5:15. So if there's something you want to know, something you want to ask or comment on, please do put it in the chat. But Debbie, please go ahead.
Yeah. So there's no space allotted for physician grief in our training in medical school. That's not true. I think some of my family medicine colleagues do make space for it in their ward rounds. I don't think it happens in internal medicine regularly. And we can have grief for the loss of a specific patient, or for the suffering that a patient is going through. I grieve for my patients a lot. Or it can be, as you know, as was mentioned, a collective, the terrible trauma and grief of COVID. I don't think we're still trying to, all of us, process that here in the Bronx. I lived through the very beginning of the AIDS epidemic, and those things are burned into my mind. They're still with me. They're never going to leave me. And I want to say again, the permission for negative emotions, again, this takes a lot of guts to say, oh my God, I'm angry. I feel ashamed. As a doctor, I failed. This person's dead, you know? All of those confusion. Did I do the right thing? What did I do? What was I thinking? And so those are powerful and terrible things to feel and to think. What is the practice? There is, again, I can tell you what the ideals would be. We really, and you know, my own personal practice, by the way, is different from yours. It's just being quiet, and I have a few trusted people that I turn to, who knew and loved the people I lost, and those are the people I turn to. That's what I do. And I would say that should be part of the practice, thinking about the physician's grief, to not bottle it up, but to try to think, who is it that I trust? Who can I talk to? And just try to do that. Push for mechanisms to discuss death as a regular part of our medical work. We should all be pushing for that. And then, you know, go to wakes and funerals. And I don't know how many people do that, but you know, it's a really good thing to do.
Yeah, as a form of closure.
It's a really good thing to do. It sounds awful, but it's really good. So that's it. That's kind of what I can offer you. It doesn't sound like much, maybe, but
No,
the hard things are the simple things.
I'm like, let me cut in on the wakes and funerals piece, like as, excuse me, as the daughter of someone who, you know, when my mom died, she just turned 49. Like now that I'm in my 40s, I realize exactly how young that was. And the doctors and nurses and, you know, receptionists and stuff from over the years who showed up at her wake, who reached out to our family afterwards to see how we were doing. Like, you never forget that. And it means so much to you in your grief that, you know, on what I assume is a laundry list of patients, that your person was remembered. Like, it is so meaningful. So I just want to double down on that one.
And thank you for that. I know that we are going to lose you in a couple of moments, but one of the residents who joined a little bit late said, you know, they were particularly interested in this idea of like grieving while Black. And it made me think of what Debbie has raised up, or what comes through your book about the collective grief of COVID, the way it impacted some communities more than others, the way it impacted all of us, but the remnants on certain communities. And so I'm just curious if there's any final words, period, that you would add, but also if you can speak to what this resident mentioned about, you know, is there anything that you would add about the particular kind of angle as a Black person in this country in relationship to grief?
Yeah, I mean, I will say the thing that I recognized and felt compelled, most compelled, I'll say, to include in my book is the role of safety in grief and in healing, and how much harder it is to grieve well, to figure out how to live with loss, and, you know, to really heal if you don't have access to safety. And for me, that's, you know, it's physical safety, but it's also economic safety and security. It's community safety and, you know, having the supports that you need. It's feeling like your grief and your feelings are really going to be honored and respected, and that you're going to be able to access the things you need to heal. And in most places and spaces and contexts, if you are a person of color in this country, if you are a poor person in this country, if
Mhm.
you are LGBTQ plus in this country, and frankly, at this point, in some places, if you are just a woman in this country, you don't have the same access to true safety. And it makes grieving and healing that much harder. And I think, particularly where you all are based and where many of you are practicing or will practice in the future, just keeping that safety piece in mind, and taking it into account when you encounter patients who are dealing with grief and loss and really all of their health issues. Like, I just think it is hugely, hugely important. So that's what I want to say on the grieving while Black piece. And if you are a person of color or in any of those other categories that I mentioned, it is so incredibly important for you to do your best to carve out safe spaces and places and people so that you can grieve and heal in the ways that you need to. My final sort of closing thoughts and words for everyone, I do not think we have fully reckoned with the grief of the pandemic. I do not think we have fully reckoned with the grief that many people experienced during the Trump years. I think there are a lot of people in this country who are suffering and struggling right now with things that they can't name that I think have grief at their core. And so, my thing to everyone is to just be really intentional about how you care for yourself and how you extend compassion and grace to yourself so that you have the capacity to extend it out to others. And I think it's even more important if you are a caretaker, as all of you are. And so I hope that you are finding ways to really care for yourselves and be compassionate and gracious toward yourselves so that you can extend the same to your patients.
That is a word, which I know you just, you always just testify. So thank you for that. And thank you
Absolutely.
for being here with us. I know it's nearly impossible to get you. So I'm grateful for Dr. Erin Goss, who suggested that we reach out. I'm grateful for our mutual friend, Oni, for making it happen. And I'm just grateful for you for giving us the time. Thank you so
And the
much,
only
Marisa.
reason why it's nearly impossible is because of that toddler. Like, make no mistake.
You work for him. Yes. Thank
So
you.
thank
Thank
you
you for
all.
spending the time with us. We are going to
M&Ms.
stay and we're going to continue with Dr. Swiderski, but Marisa, please, thank you so much again.
Thank you. This was wonderful. I appreciate it.
See you
Thank
soon.
you.
So I want to continue. I don't want to even break, and I don't want people to think that we're wrapping. I want us to kind of continue in the conversation with some of the questions that we had prepared and really been thinking through. And one of them, Debbie, that kind of specifically comes up around the how do we do this? How do we engage with this as folks who are caretakers and clinicians, specifically clinicians, is there was a wondering that we had around conveying to patients that you understand that there's space that you're making for their grief, without having to use your own as a reference point. And this kind of question and wondering came up because sometimes it feels like it is so hard to identify. And so it's easy to say, I understand this and this has happened, And one of the boundaries of the clinical experience is that it's your patient's time, it's your patient's space, and you're kind of a neutral reflection, in giving this care. So I'm just curious about your thoughts of how you navigate that space if you ever do invoke your own grief in those conversations for our patients.
Such a good question. I have tried to take the words "I understand" out of my vocabulary in the office. I've really tried, but I do fall down sometimes. And really just I just try to be present. And I guess what I'll say is repeat what I said before, is that my own losses and facing them have given me the strength to do that. But also the thing I said before about practice, the more you do it, the more you can do it. And so that, and the power of just listening means you don't have to say very much. But every now and then a certain circumstance will come up and it's clear that a patient is struggling. And I can count on one hand the number of times that I've let a personal detail come in. And those of you who've worked with me know that I am a big boundary person. So I think that we should adhere to boundaries. I think that's in the service of the patient. We shouldn't talk about ourselves. But rules are made to be broken sometimes. And so every now and then I will say to someone who, like, for example, I have a woman who's 88, whose husband died 15 years ago. He was my patient also. I was with them together through the process of his dying. She cannot stop grieving. And I finally let her know that I lost my husband. And I did that with intention as a bridge, to try to, and I just did that actually recently. So I don't know if that's going to work or not. And it was not premeditated. I did it instinctively during one visit. Whether I was right or wrong, we do not know. It's easier, for example, though, with the pets. That's a really cool boundary that you can breach. You can say, yes, I know I lost my cat or my dog. And I think it helps people feel connected to you. So I think, though, we should be very, very, very careful. I think the words that Marisa said about, everyone moves through this differently. I mean, I know I started by listing all these things that are universal. And they are universal, but still the actual personal experience and what a person wants and needs is, that's why we should be still and quiet and listening. And people will guide us with what they want. So that's a long-winded answer, but I think in general, I try very hard not to. I mean, as I process what they're going through for myself, I will use my own experiences, but I try not to share with them.
That makes a lot of sense. And I think you're right that, there's always the exception. One thing that I am aware of and that I'm thinking about is what it must feel like being a young person, having come through this pandemic, practicing at a time that feels very uncertain, unmoored. And one of the reasons that we wanted Mustafa's kind of input is just to talk about the experiences now holding grief, both collective grief and individual grief from our experiences as trainees. And I'm just, we both promised that we'd make space to kind of invoke that. And I would just be curious what you would say to our trainees and to folks who are coming up now in our healthcare system about approaches to grief, holding grief, awareness of grief. And specifically, I think one of the things that comes to mind is how they can operationalize what Marisa suggested about the safety component. And there's a quote that she has that I just pulled up about when we swallow, ignore, refuse to acknowledge what is begging to be released, we enact violence on ourselves. And so there is a demand that making space for grief, I think there's a demand for it. Otherwise, we do kind of enact a certain degree of violence on ourselves. And yet there's a reality of being in residency, being a trainee. And so just curious as we, come close to wrapping, and also opening up for any folks who have any comments or questions they may want to add to this space, but curious what you would say specifically for trainees, specifically for young folks who are, in their careers, just thinking about this journey that they're on and experiencing what they're experiencing and taking on the different types of grief that come with it.
Oh, it's so hard. There is no answer. The system is hostile, especially at the level of the trainee. Okay. The trainee
It's really powerful that you acknowledge that.
Oh
Thank
my
you.
God. Oh my God. No. And I, with all due respect to wonderful program directors and faculty, it's the system pushes the trainee, all of us, we're pushed, but particularly they are just, pushed to the limit, and the system does not support any of us showing grief or any emotion during the working time. I mean, I have vivid memories of being a resident still, and being derided for, and I was not a crier, but to show any feeling, I still remember being rebuked by the people who were over me. And I, all I can say is I mean, we talked with Mustafa a little bit, and everything he said resonated, that there is no space. Here at Social Medicine, we try to make that space. He did a session during Social Medicine Immersion Month that was highly acclaimed around this. Just sort of to create, so we could create those spaces. But I really think on rounds that there should be, like, during a 2-week block or a 4-week block, every week, there should be a time to say, we're going to process the losses we've had this week, or, if someone dies, and certainly if someone dies unexpectedly, or someone who's young, or it's a troubled situation, the team should give itself permission. The attending should give the team permission to say, let's talk about what happened medically, but let's also talk about how we feel. I mean, the whole matter of shame in our profession, we don't talk about it. And it's again, talking about violence, that does violence to us, to not face our shame, our sense of failure. So I think, I'm not asking trainees to push for this. I'm saying I think that would go a long way if on ward rounds we did that. And you set a session like this. I mean, this is a great thing to just sort of talk about it. And then finding people you trust. And I want to just call out there, I see Dr. Gorski's name here. There are a number of folks in family medicine who are just super experienced, even more than me, I would say, about these things, have thought deeply about them, taught about them. And we're lucky to have these folks around us.
Thank you.
And talk to your colleagues. Don't be ashamed to talk to your colleagues, your co-residents.
As we wrap, again, want to invite folks to share any comments or questions, and want to thank you so much, Dr. Swiderski, for the vulnerability that you've modeled and the insights and the wisdom that you've shared. And I just want to lift up, one of the things that I was thinking about in preparing for this session is what I wish I had known back in the day when I was training. And for me, it's really around shame, because I think that I was so shocked and surprised by just how devastating it was to lose patients, to watch people suffer and die, that I thought that I was extreme in my reactions. And I know I'm an empath, right? And so I thought that I was too extreme in my reactions. So I had such shame around being able to share how much I was struggling. And I think what I would share with folks as they think about their grief practice and their experience of it is to be so just loving of yourself that you find the safe spaces. And you can't share it everywhere. You can't go share it to the CEO of Monty, for instance, right? But there are definitely safe spaces, and in those safe spaces to push yourself to share. Because if I harbored shame and I saw others were experiencing the same thing as I was, I wouldn't think that they were shameful for experiencing those things. Rather, I would have thought, oh my goodness, like we have this in common. I feel seen. Maybe what I'm feeling shame about with feeling so sad all the time, maybe that's just normal. We're doing something that most of the population will never do, or watching people suffer and die on a weekly basis. And so I just want to leave that with folks as we wrap this session. And I want to also say that this is the beginning of a conversation. It's a continuation of a conversation. I know folks have this conversation or in spaces where these conversations are happening, and that this is to be continued. We offered Marisa's book as a resource. We spent a lot of time finding resources for this conversation, because we wanted folks to have a lot of things they could really look at and come back to. And we specifically chose our local experts. And so Dr. Swiderski and others who I think are real guides in this work. And yes, Shrith, in the follow-up email, we'll have all those links shared. And we'll make sure the recording goes out. And so you can really spend time with this. This is the beginning. But if there's some things that we want to make sure that are normalized for you, it's just the sense that this healthcare journey is one that comes with grief. And you can see the ways it's experienced by those with lived experience like Marisa, by those that provide care like Debbie, and that we should normalize how we engage in the practice of knowing that grief is love. And so with that in mind, I want to encourage you all to please share your feedback. We will be meeting again, I believe, in July. We're just kind of working out the details for that. And so you will get more for us for our next rounds. As always, if you have ideas for rounds, if you think there are folks who should be featured, we are super happy to craft it and do so. And I just want to thank everyone for their time and have a wonderful evening. Take care, everyone.
Bye.
Thank you, Debbie.
Bye.
Bye, everyone.
Thank you. Much needed talk.
Thank you.